Hello, everyone, and welcome to another episode of You've Got the Power, because you do. Thanks for being patient with our time off. We are back, and we are excited. We've got a great topic as you join us today. On Mondays, as you know, we broadcast live here from the Centeno-Schultz Facebook page, and today's topic is an update on early CCI data. Who is a good candidate? Who is not? There's lots of conversation, speculation. How do I know this is going to work for me? Or am I in one of those groups where this probably isn't going to work for me? Do you know? Let's find out. Of course, we're here with the Chief Medical Officer of the Centeno-Schultz Clinic in Broomfield, Colorado, Dr. Chris Centeno himself. Dr. Centeno, happy Monday. And what do we need to learn from the data that you're collecting? Maybe let's first start with how you're collecting the data so people get a sense for what exactly this project is and how it's going on.
Yeah, so I think we said a couple months ago, probably during the late summer, that we were going to start digging into in-depth data on the PICL procedure. And what does that mean? What that means is we're looking at everything from how the person got hurt, or whether they're male or female, or EDS or not, or all the way through very complex measurements taken off their DMX or their MRI, including lots of other things. How much stuff was injected at one time? Were the injections done this way or that way? Lots of different things. In fact, it's a big Excel spreadsheet, with columns this wide. And so we've done a couple dozen patients like that now who are far enough out where we feel like we have enough information on these people to start to look at trends. And so that's what we've done so far, and what we continue to do. This is a work in progress that'll probably take the better part of another 6 months to fully dive into.
Pretty interesting stuff. And that's really, I guess the scientific process is, let's put out a hypothesis, then let's start collecting data. Let's start seeing what sense we can make of it. Well, let's get into it. What sense are you able to make of what you got so far?
Yeah, so what's interesting is, and I think this is a timely topic because, I've been talking to obviously lots of patients via email. I get hundreds of emails every week. A good chunk of those now are from CCI patients or going back and forth with CCI patients. I talk to people obviously on telemedicine. I talk to them in the office when they come in for their eval, their treatment, etc. And, I'm seeing a lot of assertions being made based on what people are seeing on social media. Assertions like, women do more poorly than men, or if I've got EDS, I'm going to do more poorly, or if I've got cervical medullary syndrome, I'll do more poorly. And so we've looked through this data, and so far we don't see any associations like that. Now, that doesn't mean that they may not present themselves as we grow this in-depth look at trying to compare apples to apples, because the problem with this procedure is obviously very difficult sometimes to compare apples to apples when you've got patients who might be very different, right? Someone who has EDS or doesn't, someone who was in a traumatic injury or wasn't, someone who has certain really bad measurements on their MRI and someone who doesn't, someone who has a really bad DMX versus someone who has a DMX that isn't as bad. All those things have to be lined up for you to look at this stuff. And so far, we're not seeing any of those associations. So, meaning every time I think I've found something, we'll get 1 or 2 or 3 patients who pop up who have that thing and did great, just knocked the ball out of the park. So it's important to realize that this is an ongoing project. So far, we're not seeing any of those associations. It's certainly easy to say, well, I know 4 people over here. But obviously you can't compare that when we're looking at dozens and dozens and dozens of patients to try to see if someone's knowledge of 3 people over here is something that we see in the larger data set. So we continue to look at all of this, and it occupies a good chunk of my week every week, and it will continue to do so for the next 6 months or so until we've got some real definitive answers. But so far, in trying to look at hypotheses like women versus med, EDS versus not, CMS versus not, big instability versus little, etc., we don't see anything that's jumping out. Again, doesn't mean we might not when we get to the mid portion of the analysis or the end of the analysis, but these are important conversations to have at every stop along the way.
If you're watching and you've got questions, now's the time for you to ask. We take them as they come on in. You're, of course, talking to Dr. Chris Centeno. So let me just see if I understand sort of the context of all of this, break it down while people are typing in their questions. The goal here, of course, is, your integrity is number one, right? I've always said, the two most important things are our reputation and your health. Not necessarily in that order, but both of those things. And the goal here, of course, is to make sure that if somebody does come to see you, that you have a sense of confidence that if you accept them as a client for this procedure, there's a good to high degree that they're going to get a result that you expect and that you're looking for. If it's not general categories, what is it that you tend to look for? Is it that there's just so many different individual factors that we're not able to sort of go, here's a general statement, but how do you, when you work one-on-one with people, decide, yes, this is somebody that I believe we can make great progress with, or, I just don't think this is going to be a good outcome, so let's not, go down that road together. How do you, is it just super complex that there are so many different factors that it really is, being the doctor that determines, the weight of each of these categories, all the things you mentioned, history, health, etc. Is that the way it's done? Because I just want people to understand the goal of why you're doing all of this.
Yeah, so the first thing is to realize that we have big things and small things. A big thing would be, for instance, we just saw a patient who has such severe compression of the brainstem, definitely not a candidate for what we do. And looking at her, talking to her neuroradiologist about her films, it's suspected that she'll crash soon from that compression of the brainstem, meaning that she'll transition from just getting symptoms into more permanent damage. Now we're talking about someone whose brainstem is just getting crushed, meaning that it's 30 to 40% smaller in that one area than it should be. So that's an easy one, right? It's pretty easy to say, nope, that's not a patient for us. Where we're talking about is I would call small stuff, but it's not small to the patient. But these are finer points, like if the person has cervical medullary syndrome, is that good or bad? If the person has more instability versus less, is that good or bad as far as prognosis is concerned? And the goal of all of this, obviously, is to figure out which patients we should turn away at the door, or at least say, you know what, you're very unlikely for this to be a helpful option. We can't rule out that you might not respond, but you need to know that up front if we move forward. And we still do that all the time. For instance, I've got a patient I can think of right now that had severe inflammatory issues, and he was told up front, hey, I think that's due to a very substantial weight gain that you've had. And, I'm willing to do this procedure for the first time, but if we're going to do it for a second time, you're going to have to lose some of that weight, clean up your diet, get those inflammatory issues down. And so those are things that I can do as a doctor to try to improve the results of the procedure. But there are other things you can't change, right? I can't change whether or not you've got big DMX measurements or small DMX measurements when you walk in the room. I can't change whether or not you've got cervical medullary syndrome or not when you walk in the room, or EDS or your sex, etc. So it's really looking at those factors, trying to figure out who we should be turning away for this procedure, or at least discouraging, because obviously, we do this all the time in other things we do. If we treat a knee and someone walks in with a certain thing, I will discourage them from doing the procedure. They can still try it. It's obviously much, much less invasive than a knee replacement, or in this case, a fusion. But having that conversation up front with patients is very important to us.
Super important to you. I know that that from your side of this equation, right? There's two decisions that have to be made. The person, potential patient, has to go, I think I want to give Dr. Centeno a try and see if he can help me. One decision. Second decision is, are you willing to accept them as a patient? You're doing your best to make sure that you only accept those that you have a high degree of confidence of helping. But let me ask it again from the patient side. What are their choices? If it's not you, who do they think about going to? And I'm also curious, does anybody else do this type of, I'll call it due diligence or research, or go through the effort? Because many doctors I know, especially in this category, basically kind of say, if you've got a joint and you've got insurance, we can do something that's going to help you. Come on in. And you're sort of saying, no. We only really want to help those people that we have a high degree of confidence they're actually going to get good to great results. From a patient standpoint, how should they think about this? Are other people doing these kinds of research projects to make sure they're providing the kind of quality care that you're talking about?
No, generally not. It generally doesn't happen, especially in the regenerative medicine world. Obviously, in real medicine, it happens all the time, right? You can go in the orthopedic literature and find thousands and thousands of papers on whether or not someone is a good candidate for this surgery or that surgery. And so in real traditional medicine, that happens all the time, or whether or not someone's a good candidate to take this drug or not. Now, sometimes it doesn't always get applied that way, but there's lots and lots of research being done out there. In the regenerative medicine world, it's far more sketchy, right? We generally don't see that happening. You're a candidate, pretty much everyone's a candidate who can afford the treatment, and if it doesn't work, it doesn't work. So from our perspective, we've always done that differently. I'm the chief medical officer for Regenix, and we've always looked at our data trying to find out who's a good candidate, who's a poor candidate. So for instance, I can tell you that if you've got severe hip arthritis, we can't help you. There's nothing about anything that I do that will help your hip. You need a hip replacement. Now, we're probably the only group of clinics in the country that will tell you that. Everyone else will say, hey, come on in, we'll give this a shot, see if it helps your hip. So looking at that data takes a lot of time, energy, and effort. And again, we're going to continue to look at that data. We're going to continue to dive deeper into it. And I'm very hopeful we'll at least be able to find 3 or 4 things where we can say, hey, if you've got these 3 or 4 things, you're less likely to respond. So you need to know that up front.
And corollary, if you've got these other things, you may be a good candidate. And I think that's, again, what I just commend you for. And I just want to make sure we got a lot of viewers watching, many who are regular viewers. I can see Rachel and several others, so thanks for always tuning in. But some new viewers as well. And, often I don't think people appreciate, I'll say, the context. They're like window shopping, which doc should I go to? They're all the same, when in fact they're not. I tend to refer to you as the Elon Musk of regenerative medicine, and it's for this very reason that it's the candidate qualification is not can you afford the procedure. It's are you a good candidate for the procedure, and I just like to make sure people understand that all doctors are not the same. They're not trained the same, and they don't focus both their integrity and effort work on these types of projects because you don't get paid to do these things. The only thing it provides for you really is a sense of integrity and a sense that you're doing the right thing, and hopefully afterwards a matrix of some sort for people to be able to have a good degree as to whether they'll be good candidates or not.
And that's an important thing,
Yeah.
Jason. We don't get paid to do these things, meaning that we have a full-time PhD lab research staff. We have a full-time PhD clinical research staff. We have fellows in our clinic that can assist with research projects, but we don't get paid to do it. It's all a cost center. And this isn't being supported by some government grant or some money coming raining down from somewhere. It just costs money that doesn't get replenished or replaced. But it is critical to do, and if anything, it'll reduce the amount of income we can make, right? Because at some point, hopefully, we'll be able to say, you 35 patients out of 100, you really shouldn't be doing this. That doesn't increase income, that decreases income. So there's another reason, however, to do it, and that reason is that it's the right thing to do. That's what real medicine looks like. Real medicine always has some sort of candidacy matrix where you can sit down with the patient and say, you know, you're a really good candidate for this procedure, or you know what, you're really not. Since it's relatively low risk, you can try it, but I want you to understand that going into this, you're going into it eyes wide open.
Excellent. Love it. You got to love integrity in healthcare these days. Unfortunately, it is rare to find, so that's why we highlight it when we can. You ready to take some questions?
Sure.
From other people besides myself, that is.
Yeah.
All right, here we go. This one was submitted in advance by Shari Gupta. She asks, does CCI from an accident ever heal on its own? Great question.
Yeah, that's a really great question. And the answer is probably more often than not, right? There are lots and lots of patients who sprain the upper cervical ligaments, just like you can sprain an ankle. And, you know, as you know, if we take 1,000 patients that sprain their ankle, probably 800, 900 are going to be just fine. They're never really going to have a long-term issue. Now, we can separate those people out by time. So you might say, you know, if it heals within the first 60 days, that's very different from the patients who are 60 days and it still hasn't healed. And then you could probably also come up with another group that says if it heals in that first 6 months, that's very different from the group where it doesn't heal in that 6 months plus. So I think here we can probably break those patients into group. I assume what you're asking is in the subacute or the chronic, meaning the ones that are in that 2 to 6 months or 6 months greater, can it heal on its own? And listen, we've seen some interesting things. For instance, Evan Katz locally is a chiropractor who does curve restoration, and he has treated some CCI patients. He's restored their curve. Presumably, what has happened during that time is the weight was taken off of those ligaments, and they were finally given a chance to heal. And some of those patients have done very, very well without any intervention outside of curve restoration, including showing improvements on their DMX. So the answer is yes, it can. And obviously, you know, we would only want to intervene in someone where it's clearly not healing.
That is a great point and a great question. Thank you for asking that. Rachel Riggs comments, hey, Rachel, she says, I'm a month post-PICL. Now I wait. Smiley face. Any comments on that?
Yeah, I think what Rachel is referring to, and this is an important concept, is that, you know, people break into lots of different groups here after the procedure, but in general, we're waiting for that first 3 or 4 months to see how someone responds. You can see that in some patients early at 2 months, other patients it takes 3 or 4 months, but we certainly want to give enough time for remodeling of the tissue to occur, and then to see how the patient is feeling, whether or not they're noticing any substantial improvements that they can hang their hat on. And when I say hang their hat on, these are things that are definitely better. It's not, you know, I got to think about it, maybe I'm a little better here or there, but they're definitely better in order to move on with a second procedure.
Personalized medicine at its best. Everybody's a little bit different, and having the kind of relationship and, I'll dare say, access through this show and directly through the office is a unique and very special thing to be able to have. Let's keep going. Lots of questions coming in. This was submitted in advance by Harry Winston, who says, I read your blog about PRP. I'm 55. Would my age eliminate me from being a candidate for your PICL procedure?
No, I mean, the good news is when it comes to that sort of stuff, we've already adjusted for that. So, what I mean by that, Harry, is that at the end of the day, let's kind of review what Harry's talking about because some people may not have read that particular blog. That blog comes from some published research that we've done that shows that platelet concentration is critically important as you get older and less important if you're younger. So we use the term X, 3X is 3 times more platelets than you would normally have in your blood. 10X is 10 times more platelets. So if we use a 2 to 3X PRP, a very low concentration, in someone like my son, who's 17 years old, you can get away with very low concentration platelets being used. And there's a specific reason I go into the blog why that's the case. In someone who is older, especially someone who is what I would call NFL over the hill. What I mean by NFL over the hill is we all know that we have our favorite NFL sports stars. They generally don't last much longer than age 35. There are a few freak athletes who can do it, and there are lots of people who fall out before that age. But on average, if you looked at the age of retirement of NFL athletes, it would be about the mid-30s. Now, why does that happen? It's because the natural growth factors that help with repair have gone down, so they can no longer natively repair the beating that they get every weekend when they go to play. And so if you're in that 35 and over age group, then you're getting into that situation where you need higher dose PRP. And that's what the blog discusses. And it discusses our research on that topic that we've published. It discusses just some general diagrams of why that's the case from a scientific standpoint, talking about receptor density. And then it finally gets into this idea of what you need. Now, the good news is, Harry, when it comes to PICL, we've already made that adjustment for you. So, for instance, if you're coming in at 55, instead of using that 2 to 3X PRP that would work well in my son, we've already bumped yours up to 14X PRP in that bone marrow concentrate. So we've already taken care of that adjustment for you.
Great point. And if you are not already a subscriber to Dr. Centeno's blog, can't recommend it highly enough. If you really want to know how your body works, if you want to stay on the cutting edge of regenerative medicine and understand really what's going on in orthopedics as well, you really want to make sure you subscribe to the blog. You can go to regenx.com, click blog, make sure you sign up and receive what I think of as a daily dose of smart. You read something every day that you at the end just kind of go, that was a very worthy few minutes. I am smarter because of it. So I highly recommend it. Check it out. Let's keep going to, I'm going to say Tina. Hi, Tina. My C1 won't stay in alignment. I had a head and neck injury 3 years ago. Would I benefit from PRP?
Yeah, so I think, Tina, a lot of that comes down to the reason why and which ligaments are involved, etc. But let's say that you've got a C1, C2 rotational issue that maybe is due to laxity of the Centeno-Occipital ligament, which is one that we can hit from posterior. So getting some X-ray guided injections into that ligament with contrast to make sure that we're in the ligament might be very, very helpful if we use PRP. But a lot of it's going to depend on what's going on. Now, the good news is that posterior prolotherapy PRP is pretty widely available. You've got to be a little careful because you're going to kind of get the plain Jane version versus the more complex version. So the plain Jane version is just kind of putting the needle into the supraspinous, interspinous ligaments, perhaps along the facet joints, just kind of resting it on the bone there. And that can help some patients with mild craniocervical instability. Then we get into the next level version posteriorly, where we're injecting things like that Centeno-Occipital ligament, where we can use PRP for that, where we're injecting PRP into the upper neck joints using X-ray guidance and contrast. But listen, posterior prolotherapy and PRP is fairly widely available. Not too hard to find someone locally who can do a reasonable job there of doing the plain Jane version. And certainly reasonable thing to try if you've got more mild CCI to see if that helps before you invest in a bigger workup, or if you're that kind of person who just has to know exactly which ligaments, or is this something that's likely to help me, then getting a DMX would be helpful. For instance, if you've got 7 millimeters of overhang at C1, C2, it's very unlikely that any posterior injection is going to get that done. So two different pathways there, depending on really personality of the patient, right? There are those patients who would say, let me give this a shot, see if it helps. And there'll be those patients who say, no, I want to know before I do that whether it's likely to help.
I'm going to see if I can ask a few more questions on Tina's question. It's my understanding that there's really 3 different types of criteria that are sort of part of this decision-making process. One is making sure you're using the right orthobiologic, PRP, bone marrow concentrate, whatever it may be, in the right formulation. That would be one. So can PRP help is one part of the 3-part question. The second part is, as you mentioned in the plain Jane, I guess my question on that is, how often do other doctors use image guidance? And how important is it to use image guidance to get better results? Is that high priority, low priority? Doesn't matter if it's not that bad, matters only if it is bad? Or isn't it always important to get the right stuff in the right place? Which leads me to the third category, which is their training. I think, as you've said many times, if anybody's reading the blog or paying attention, a lot of docs sort of take on or start offering these new procedures because there's just so much demand for it. So they just kind of go, sure, we offer PRP, but they really haven't invested a lot of time to become expert in it or even very well trained and competent in it. I'm guessing that's what Tina's sort of asking is PRP right? Do I need image guidance or not? And maybe what kind of questions should I be asking about how extensive their training is on that on these types of topics?
Sure. Well, these are fairly complex issues that I'll try to make as simple as I can. First is, prolotherapy, PRP, bone marrow. In general, really, it's just the amount of oomph behind the treatment. So PRP, more treatments will be needed compared to bone marrow, and then prolotherapy compared to PRP, more treatments still will be needed with prolotherapy. So, fewer treatments as you go forward in that, and kind of a stronger effect on ligament healing based on what we've observed through the years. Then we've got the next issue of guidance or no guidance. Definitely guidance, obviously, in the neck. So you want to make sure they're using ultrasound or X-ray so that they can at least guide that needle. But then you've got just using ultrasound or X-ray and then doing specific injections into specific structures where you need X-ray and contrast. So that's a whole other level of training above that. For instance, I could train a fellow, like the guys that are constantly in our office learning, how to do simple cervical prolotherapy with an X-ray unit in the better part of 2 days, and they'd be relatively competent at it. Now we get into the next level, and if I say I want to train them to inject all the cervical facet joints, including C0, C1, using contrast to make sure they're in the joint with, let's say, PRP, that's a year project. To be able to teach them how to get into all those joints reliably, and in particular the upper cervical ones, without permanently damaging or injuring somebody because of all the critical structures that are there. So lots to unpack in that question with regard to what's used, what imaging is used to get it there, and then the level of experience of the doctor that's required and training that's required to be able to pull off those kinds of treatments.
I'm hearing you say image guidance should be a requirement. So if this is about learning how to ask the right questions, if you're doctor shopping, so to speak, then requesting or making sure that they're capable of image guidance. And then as it relates to training, I know you're involved with the IOF. Are there any specific ways of asking a doctor, do you have a specific certification or training of some sort that the doctor could, that the person would be able to better assess that's a qualified good training versus every doctor's of course going to go, sure, I'm trained in everything, I'm a doctor. But are there any specifics that you can recommend that they would go, are you trained by a particular organization, group, or even yourself?
Yeah, these are hard questions to answer with regard, but let's focus on CCI, right? Since I think that's most of our viewers today. So if we stick with CCI, then as far as trying to find the right doctor, if we're talking about the more complex stuff like upper cervical facet joint injections, I think you've heard me say it many, many times on this program, at the end of the day, that's really hard to do. And even incredibly advanced spinal interventionalists who have done thousands and thousands of X-ray guided contrast confirmed procedure. That means they're injecting in radiographic contrast to make sure they're in the right spot. Even if we take that crew of, let's say there's 1,000 US doctors in that category, probably only a handful of those doctors, meaning this many, have done those upper cervical injections, 0, 1, and 1, 2, more than 2 or 3 dozen times in their entire career. And as I talk about a lot, that's not much. Think about yourself. If you do something, let's say you're just learning to play the guitar, and you've played the guitar 2 or 3 dozen times, maybe you know what you're doing a little bit, but you're not a good guitar player. It would take hundreds of times to get passable. It would take thousands of times to get really good and to sound really good. So it's the same thing here. It's no different when it comes to that sort of stuff. What questions can you ask doctors on the simple prolotherapy or simple PRP into ligaments? Do you use guidance is a good one. And where did you learn how to use that guidance to inject those ligaments? So those are general questions, or frankly, if we're doing a CCI evaluation and you want me to take a look at someone's website, I can usually figure out in just a minute or two whether or not that person is qualified, how they're qualified, what level they're operating at, and that's not hard to see. What is hard to do is try to explain that skill to somebody else easily.
That is a very difficult one. One of the hardest questions I get is, I don't live near you. Which chiropractor should I see somewhere? And yes, going to a website, usually if you know what you're looking for, you can pick it up pretty quickly. All right, let's stay on with more questions. We got a lot of them. So here we go. Mike Vowell says, I started symptoms about a year ago, but without a car accident other than one 8 years ago now. I'm pretty highly functioning and improved with my posterior prolotherapy. Have been approved as a candidate for PICL, but when talking with the team at CSC, I was told that, and then the question cut off. Let me see if it comes up. I'm going to read the next part of his comment. Here we go. I was treated in Florida with posterior prolo and got some benefit. I have a 5 millimeter overhang in their DMX. I was approved as a candidate for PICL, but when talking to the CSC team, I was told that highly functioning people like me and with a potential old injury, I'm less likely to respond. Is that true?
Yeah, we don't have any data that shows that. I mean, personally, I think I've got some sense that if you've got a really old injury, this may be harder to treat. But that's just my own doctor's intuition involved there. But when it comes to highly functioning, I think what they were probably telling you is, this is a procedure that has certain risks. And the question always is, should you take those risks if you are a high functioning person. And I always ask the patient the question, is this substantially disabling? And it's interesting, you know, when I talk to someone, they sound high functioning, and then I'll get into, is this substantially disabling? And sometimes they talk about in more detail how it impacts their life, and then we cross that line. But let's say they had that conversation with you and they never crossed that line. Therefore, I think we've got to err on the side of caution and say, you know what, maybe this is not the right procedure for you right now. Maybe another 3 or 4 years, once we've done 1,000 more cases, we can say the risk is so low that for high functioning patients who are just looking for a bit of improvement, this makes sense. But I think that's the conversation that was being had there. Does the level of disability warrant the procedure? And that's the same conversation, obviously at a different level, that you would have with a surgeon who wants to fuse your upper neck, right? If you walked into a surgeon and said, you know, I've got CCI, but I can work out fully, and what I'd really like to be able to do is up my weights, because every time I try to up my weights, my CCI gets me, they're not going to operate on you. The risk of the procedure is too high relative to what it is they're trying to accomplish functionally. So it's the same thing in a different conversation, because the risks for PICL are nowhere near those for upper cervical fusion.
I'll also point out, it's so funny because most doctors' offices will err on the side of, sure, just come on in. Your office errs on the side of, well, maybe not. And that's, again, because, you know, you're really focused on your integrity and making sure that, you know, those that you say, yes, I'll accept you, can expect a reasonable to good outcome. Would you recommend that Mike do a teleconference with you perhaps, or if he's local, come on in and get a personal professional opinion from you directly?
Yeah, always happy to do a telemedicine eval and take a look at what was said, what's going on, etc. So happy to do that, Mike, if you would like, for another look at all of this. But just again, realize that if the conversation is about making small incremental improvements, then we're going to err on the side usually of saying, let's not do this right now.
Sounds great. Okay, we got Pia. Hello, Pia. There's a couple here, so bear with me. Thank you for this great information. What about the opposite? Can you say something about which people who tend to do poorly after a PICL procedure? I see a few people reporting a real struggle after, which is worrisome to me. Have you any data on this subject yet? And then her second question that's right there also says, what is your thinking about cranial settling as a factor for outcome?
Yeah, so it's the same thing, Pia. We're talking about both sides of that fence, you know, do well or do poorly. So for instance, when I mention things like cervical medullary syndrome, the theory would be there, if you've got cervical medullary syndrome, then you are more likely to do poorly. So it was not you're more likely to do well. So we're definitely talking about that today. When it comes to cranial settling, that's a good question. I can't say that we have enough patients with significant cranial settling to answer that question. I do know one of the things I see is many times what's called cranial settling is really a lack of a normal curve in the neck, meaning that in many patients, when you take away that normal cervical curve, the distance between the skull and the dens gets smaller. When you put that curve back in, the distance between the skull and the dens naturally gets bigger. So I think we've got to be careful with that term. It's not just a measurement on an X-ray or an MRI, but a measurement in the context of what else is going on with the spine. So I would definitely encourage you to have someone look at your cervical MRI and see if you've got straightening, because we've seen a lot of patients who've been diagnosed with cranial settling, but they really just have a loss of curvature in their neck, which makes that distance smaller, and you get the curvature back and that distance becomes more normal. So just be careful with that. But we don't have enough patients who I would consider to have really legit cranial settling to make that determination.
Right on. Let's move on to Shanzeh Khan. Hi, Dr. Centeno. Is it safe if PRP touches the dura? And can you inject near the carotid sheath if it's getting injured by, let's say, a chiropractic thrust?
As far as PRP touching the dura, we've been injecting PRP around the platelet products and PRP around the dura for, I don't know, decade and a half now, in thousands and thousands and thousands of patients. So not a problem there as far as PRP touching the dura. In fact, PRP or platelet lysate injected epidural, which is above the dura and touching the dura, is much more effective in what we've seen and observed than something like epidural steroid injections. So I think that answers that. The second question, Jason, was?
Can you inject near the carotid sheath if it gets injured by, yeah.
So it's possible, although I don't know why. It would depend on what it is we're trying to accomplish there, meaning that the only time we would be anywhere close to the carotid sheath would be if we were doing something like an under the sternocleidomastoid higher dissection of the superficial cervical plexus. There we'd be a little close to it, and that would be, again, platelet products. We would never inject into the carotid sheath, however. We're still quite a ways, the needle would be quite a ways from the carotid sheath. So I wouldn't recommend injecting into the carotid sheath at all.
Excellent, thank you. This is from Roger Chin. Hey, Roger. He says, I've had difficulty recovering since my September 17th dextrose prolotherapy and September 30 PICL number 3. You warned me about the long flare trajectory, which didn't happen with many prolotherapies and 2 previous PICLs where I progressed well. ME/CFS researcher Dr. Klemis said COVID vaccination could cause an ME/CFS relapse. After 6 weeks, my wearable data is starting to normalize. Any recommendations? I'm on the stem cell formula and other anti-inflammatories and antihistamines for MCAS. Thanks.
Yeah, this brings up a good point, and we're seeing, I would call patients who are probably not doing themselves any favors by inserting additional treatments. So we see patients who are asking, can they get another prolo done in between their first and second PICL or another PRP injection? And we've seen enough evidence of things going poorly when that happens that we're now saying, no, don't do that. Let's wait from your first to your second before you do that. And then the other issue is, as far as the COVID vaccine, listen, I don't know how anyone could make that determination at this juncture with regard to what effects the vaccine would have, meaning that you would have to obviously observe that in lots and lots of patients. The problem is that vaccination is a common event these days. So if you saw somebody who had certain things, it would be really, really hard to say it was due to the vaccine or not, since vaccination is common. You would have to have an uncommon event. So for instance, let's say you get into a car crash, and we know through 100 years of experience that car crashes can injure people, and car crashes are relatively rare events. So that, and if you had symptoms, an hour after a car crash, all the definition of causation is met there. We've got a temporal relationship between the two things. We've got a biologic explanation of why car crashes can cause neck pain, and we don't have anything else during that time period that could cause your problem. Hence, there's probably a pretty good relationship between the two. But as far as the millions and millions of people, in this country, hundreds of millions that have been vaccinated, or 100 or 200 million, that's a really hard thing to do. So I would say, I don't see how that's even possible to draw that connection between ME/CFS and vaccination, given that you would have had almost, or at least 50 to 60% of your entire patient population vaccinated. So we're not talking about a rare event now. We're talking about an event that happens in 6 out of 10 of all of your patients. So hard conclusion to draw.
Any specific recommendations you can offer, Raj, and helping him feel a little bit better as he gets through this one?
Yeah, only to contact your doctor who did your procedure and ask these questions.
All righty. Thank you, Raj. Hopefully that helps you. Shenza follows up with, how do you differentiate between a PLL injury or an ALL injury without a DMX? If providing support at the frontal sides of the neck feels better, is it an ALL issue? Thanks.
So ALL would be, just to kind of review here, the ligament that's the duct tape in front of the spine or in front of the neck. The PLL would be behind the vertebra there, between the vertebra and the spinal canal. As far as which one is injured, and can you determine that without a DMX? Sure, for instance, if there's retrolisthesis, meaning one vertebra behind another, on, for instance, a stand-up MRI, you could probably conclude that it's more likely to be ALL than PLL. Or if it goes the other way, then it could be PLL or any of the posterior ligaments. With regard to which one should be injected, the answer is the one most affected, but when it comes to doing the procedures from the front, PICL, we're definitely going to tighten the ALL or inject the ALL as we come out, because there's really no reason not to. There'd be no downside there. So I'm not sure if that answers the question, but just sort of a discussion of what needs to be injected. But you're right, a DMX is a good thing in trying to help make those decisions.
Very good. Let's move on to Mike. Follows up. Mike says, is the fact that I'm highly functioning a plus or a minus for me? Am I more likely to go backwards if I'm dealing with things right now, but have relatively large amounts of suboccipital pain? In summary, is it important to go the route of getting regenerative treatments ahead of further damage, or is it better to wait until we are bedbound? It's a great question.
Yeah, I don't think it's, again, there's a lot of daylight between highly functional and bedbound. So I have a functional scale that I've put online that kind of gets into this, right? You've got folks who are bedbound on the one end, you've got folks who are still working out and have CCI on the other end, but there's a lot of room in between those. For instance, you can say that someone's highly functional because they can still take care of their kids, but they're otherwise miserable, and they can still work, but they're otherwise miserable and really struggling to keep up. So, you know, that person, I would say, is definitely a PICL candidate. Now, you've got someone on the other end of that spectrum who's more functional than that. Let's say they have no problem keeping up with work, they've got no problem keeping up with their family responsibilities or their chores, but there are things they don't do, like, you know, they don't lift heavy. They stay away from certain things in the gym because they know that will flare them up. Now we're getting into the kind of person where you would really draw a question mark as to whether or not you'd want to do a PICL in that person. So just realize that there's a lot of daylight between those two extremes.
Great questions, Mike. There we go. Great questions, Mike. And again, that might be a personal, get your specific individual questions about your body, your experience, as opposed to the generalities, by setting up a telehealth consult with Dr. Centeno directly. Might be the way to get the specific answers it looks like you're asking for. Tough to diagnose over the internet like these in generalities. All right, Shamza follows up. Have you ever had a patient who felt worse after cervical PRP? I understand that some people may not have improvements, but can anyone worsen from baseline? Thank you.
Oh yeah, I mean, any chronic pain patient with anything, whether it's chronic back pain, whether it's chronic neck pain, whether it's CCI, whether it's chronic whatever, there's always an extremely small percentage of the population who can be either long-term worse or permanently worse. Now, long-term worse is someone who is usually centrally sensitized, someone who has a hard time even tolerating a massage. So these are generally patients who, let's say they go for a deep tissue massage, and they'll end up in pain for weeks as a result of that massage. So those patients can definitely be long-term worse. Now, the good news is there are always a very small percentage of the population. And then you've got the permanently worse, that's even, again, a smaller percentage of that population. But there is no procedure ever devised by man, I don't care what it is, that doesn't have a rate of making someone worse. Surgery, obviously, there's a large percentage of people that are worse. And again, the bigger the procedure, the higher the percentage. The lesser the procedure, the lower the percentage, right? It would be very uncommon to hear someone who had a massage and that massage made them worse for the rest of their life. Is it possible? Sure, there's probably people out there that fall into that category, but they're few and far, far between. More likely is you had a low-level procedure, it made you worse for some expanded amount of time, and 99.999% of the time that doesn't happen. But absolutely, there is no procedure that we do, there's no procedure that anyone does where there's zero chance of getting worse. Doesn't exist.
Doesn't exist. All right, you doing okay on time? We got a few more questions?
Yeah.
All right, great.
Sure.
Justin Eddy asks, in the past, you've mentioned that the length of time between injury and treatment may be a contributing factor in failure of PICL, but there wasn't enough data to confirm this. Any update regarding that hypothesis?
Yeah, Justin, we're still not seeing it, but that also could be because of the small N of people who we consider completely done with their treatment. So that one is still a suspicion I have. It's not a suspicion I can confirm right now, but it's still a suspicion I have. Meaning, at the end of the day, it's certainly possible that's there, and we're just not seeing it because we've got a relatively low N of those people who are completely done. Meaning, in order to be able to answer this question, you can't just take someone out one treatment, although some people will have one treatment then stop. You've got to take enough people out who had 2 or 3 treatments as well. And since these things are being sequenced every 3 to 4 to 5 to 6 months, that's someone who's usually 1 to 2 years into the cycle in order to say, yes, I know exactly in which bucket to put that person. They were a non-responder, or they were a somewhat responder, or they were a knock the ball out of the park responder.
There you go. Ilmas Ashraf just wants to say hello. He says, hello, doc. All right, let's go on to Kristen. I had a crackling chiropractor injury 2 months ago. I'm already feeling head pressure with neurological symptoms, autonomic dysfunction, blurred vision from the pressure, occipital pressure. Hard to hold head up. Although I'm having big symptoms so soon, would I still be a good candidate because it's soon after the injury?
Yeah, realize, Kristen, when we look at, where to draw that line for natural healing, it's usually around that 3-month mark, very similar to the line we have in starting to look at PICL outcomes, or starting to look at someone's rotator cuff injection outcome. You got to get to that 3-month mark to get as much, or at least to get enough natural healing where we can say this is something that should have healed on its own, but for whatever reason didn't. So I think this would be a great time to see an AO or a NUCA chiropractor, or if you've lost your curve, a curve restoration chiropractor, or a highly experienced manual physical therapist, and give this another month to see which bucket you're in. If at the end of that, you're firmly in the I'm not getting any better bucket, then that's a good time for us to start taking a look.
Tina follows up with, I do have mild CCI, and then follows up with prolozone ?
Should you get prolozone?
That's my interpretation.
Yeah. So again, my sense is give it 3 months to fully heal on its own. And that's the time that you should be getting supportive care, conservative care, rather than injection-based care.
All right. Mike is going to give this one more try here, so let me read it out to you. My cervical CT is normal. Brain MRI, normal. Anterolisthesis on X-ray looking down. DMX of 5 millimeters overhang. Last accident was 8 years ago and no symptoms until a year ago. I'm highly functioning but also have some high-level suboccipital pain that limits my life. Is this a candidate profile typical for PICL?
Yeah, again, if you're high functioning, I think we would end up and you have those issues, we would probably recommend lower or less invasive care initially. So for instance, suboccipital pain. Lots of things cause suboccipital pain, including an injury to the upper cervical facet joint. So for example, I'm not saying this is what this is, injecting those upper cervical facet joints is less risky at this point with the information we have than going ahead and doing a PICL procedure. So that's probably the direction we would push you in. And Jason, I do have a 2 o'clock meeting, so I do have a hard stop at 2, just to give you an FYI.
All right, we do have a few more questions, but folks, we're going to do our best. This is the reason to get in early and ask early, but I know as the conversation goes on, questions continue to come up. So accept both of our apology for having to end it, I won't even say short, for not being able to go extra long this episode. But we will be back on Friday on the Regenx page. We'll be back here next Monday, back on this page. Please, if you need to, write down your question, take a screenshot, make sure you ask us next week. That's what this is all about. We love serving you. We love making sure that you get the answers to the questions that you need. That's what we call You've Got the Power. All right. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. This is You've Got the Power. Join us Friday on the Regenx page for more. Until then, stay well, be kind, and thank you for watching.